Yeah, go for it whenever you want, Andrew.
Yeah, sure. Okay, so we're going to be covering opioids today. So just a few things that you need to know for opioids. It's not really a tough topic. Just need to know a few drugs and how it works. So basically, the mechanism of action for opioids is that it acts on the opioid receptors within the brain and just prevents the transmission of pain signals. So those are in your C fibers. And so when you activate these opioid receptors, they actually inhibit the transmission of pain signals, and they only counteract slow pain and not fast pain. Because slow pain is transmitted through the C fibers and fast pain is transmitted through the A fibers. And you'll learn quite a few receptors, but the main one that you need to take away is the mu receptor. So it's activated by the activation of the K plus current, and it just causes hyperpolarization, and it inhibits CA2 plus channels. Yes. So if you notice, the opioids basically occur in your spinal cord, either in a pre-synaptic or post-synaptic. So it happens after your dorsal root ganglion. So it happens usually in your CNS. Yeah. And so there's a few types of opioids. There's either endogenous or exogenous. So endogenous just means produced in the body. So you've got, so these are just mainly small peptides produced from neurons, and the exogenous, basically they're your endorphins and gasoline, and your exogenous opioids are externally synthesized, and they mimic the effects of endogenous. So your drugs are your exogenous opioids. So your targets, like what I was saying, the main one you need to know is the mu receptor, and they are found either in your spinal cord or in your brain. Yeah, it's basically what you need to know. And going down. So you need to know a few effects of opioids. So it causes analgesia, it causes respiratory depression, depresses the cough reflex, sedation, and these are the main things you need to know. And there are quite a few adverse effects. So if you take too much of opioids, could lead to constipation, because it basically inhibits your gut motility, and can also cause respiratory depression. And this is treated basically with naloxone, which is an antagonist of the opioid receptors. There's a few others which you can also read through as well, but these are the main ones. Like, these are the buzzwords that you'll see in exams as well. So moving on, you'll have to learn quite a few different drugs. So there's morphine. So basically the mechanism of action of morphine is the same. It's an opioid receptor agonist, a strong opioid, and you just need to know the adverse effects. One key thing is constipation. Moving on, so fentanyl is even stronger than morphine. So it's 150 to 100 times stronger than morphine, and it causes respiratory depression, bradycardia, and usually uses when there's a breakthrough pain, like really severe pain. And another drug you need to take note of is loperamide. So this is actually poorly absorbed in your GIT, so that's why it's only selective in your GIT. It doesn't act on your CNS. So it basically is an antidiarrheal, and so in adverse effects, if you take too much of it, it can lead to active constipation. Naloxone is a drug which is basically opposite to all the other drugs. So it's basically an antagonist, not an agonist. So it's used for treatment of opioid overdose. And so the withdrawal, so the adverse effects is that it could lead to withdrawal symptoms, and it could lead to hyperalgesia. So for treating opioid addiction, there's a few steps you usually follow. So usually you use substitution therapy. So you use an agent which is longer lasting, less potent, and after that you try to substitute for a lower intensity And finally, you try to use naloxone, which is basically an antagonist, and it's just to treat your, it's basically used for opioid withdrawal. And yeah, so this is the analgesic ladder that you can take note of. So your strong opioids are your mainstream ones, and usually used for moderate to severe pain. Then you've got weaker ones like codeine, and finally you've got non-opioids. So you shouldn't confuse like paracetamol, aspirin, or NSAIDs with opioids because it's completely different MOA. Yeah, and there are a few other drugs that you can take note of. It's not that much of a high yield, but it's always good to know them as well. So basically all of these are opioid agonists, and for tramadol especially, it can enhance serotonin transmission. It's usually used for chronic pain. And yeah, dextromethorphan doesn't have any analgesic properties, but it suppresses cough. And codeine is um, it's converted to morphine, so it's less potent. So yeah, that's what you need to know for opioids.
Sweet. Thanks, Andre. Enjoy lunch. Okay, cool. So I think we'll do Kahoot. It's a pretty short Kahoot. And then I don't know who wants to go first for content, but I don't think there's too much. So yeah, I'll go through Kahoot. All right, I think we can get started. Otherwise, you can just join in the middle of it. And that's all good. There are only about like 10 questions, I think, in this Kahoot. And then some fun questions at the end. So that should be good. There's a bunch on like relationships, I think, like adult relationships, and they're kind of just statistics. Yeah. Cool. So adult friendship doesn't necessarily have to be physical. Affective, just referring to emotions, social ability, and shared kind of means just like it's a mutual friendship. So it's not just one-sided. Friendships don't have to they don't have to have a physical aspect to it. Oh, whoops. Sorry, that was just meant to be 12 months. So yeah, apparently you have to live separately and apart for 12 months in order for the court to allow you to have a divorce. So that should just be 12 months. And you would have to prove that through other means. Yeah, nice. So compatibility isn't a component of love, whereas commitment, intimacy, and passion are. Longer term relationships kind of have a greater level of commitment, even though they might have a lower level of intimacy and passion. But compatibility is not one of the basic components. Yeah, so it is unfortunately high. Well, fortunately high that it is reported, but unfortunately high levels of domestic violence that do occur. And it's 43%. So I guess what this kind of shows is the importance of primary care and yeah, like forming that trusting doctor-patient relationship. And yeah, remembering that confidentiality is really important. Yeah, good. So it's talent in this case. Yeah, talent doesn't necessarily affect your career choice because I guess many people go into their careers because they want to get good at it. And you don't have to go into it. So you don't have to have a high level of talent to go into it. Like, for example, none of us know how to be doctors in high school, and yet we still chose this. Whereas kind of our ability to do things, our interests in things kind of medical and things to do with people, as well as our personality types, will probably guide our career choice more. Good. So petechiae are non-blanching. So petechiae are kind of like these small little red dots all over your skin. And essentially they're capillary microhemorrhages. So they're really, really tiny bleeds. I think petechiae, I think it's a buzzword for vitamin C deficiencies as well. But the thing with petechiae is that if you press on it, they won't change color. They'll just stay red. And that's what the blanching ability kind of refers to, or the inability for this case. Yeah, good. So in this case, it's cellulitis. And I guess the unilateral swollen and shiny leg, that's a bit of a buzzword, especially the shiny bit. That really indicates cellulitis. And that's caused by Staph aureus or Strep pyogenes and involves the subcutaneous tissue. You also get a bit of a fever because it's an infection as well. Good. So this one, yeah, it's syphilis. This one will come again. This one will come up again, sorry, next year in year 2. And syphilis is, it's essentially a STD. Gonorrhea is also an STD, but that's caused by Neisseria gonorrhea. Cellulitis is what we just went through, so Staph aureus and Strep pyogenes. Then vasculitis is referring to like the vascular system and like inflammation of your vessels. And that's not really involved with treponema pallidum. Yeah, syphilis is a scary thing. You'll learn about it next year, but it's pretty scary. Good. So we have two types of herpes simplex, type 1, type 2. Type 1 is kind of to do with more of your your cold sores. So like these kind of sores around the edge of your lip. And those are kind of transmitted by saliva, whereas your HSV type 2 is a general infection. So that one doesn't really cause cold sores, and more so it causes like genital ulcers, blistering. Yeah. Good. So HPV can cause cervical cancer. But the good thing about this HPV virus is that there's a vaccine. I think all of you probably all of us would have gotten it in high school. And that's a Gardasil vaccine made by an Australian. Good stuff. Yeah, really, really drops your chance of getting if you have a cervix, it drops your chance of getting cervical cancer. Then I think this is the last proper question. Good. So this one, so HIV is normally transmitted through bodily fluids, but the one that is not transmitted through is saliva. All the other ones can allow for transmission.
Excellent question. Also, very quick, just one trivia note for HSV1, HSV2, you don't need those for exams, but there is an increasing incidence of HSV1 causing genital herpes, possibly because of oral sex. But yes, fun fact for you.
Fun fact. Learn it again next year as well. Why did you guys pick this one? I don't know who wants to go first for presentations, but yeah, you guys can decide.
Yeah,
we should do a Pingu Among Us. That'd be hilarious.
It's always red. Cool. Good job, everyone. Congrats to, I think help came first. I don't know, maybe you should help everyone else. But yeah, I'll put this up afterwards, or right now, and then you can go over it in your own time if you like. Otherwise, Zoe will present.
Yeah, HLSD is actually very, very high yield. So study hard. Okay, so I'm covering microepi-emerging infections. I don't actually know if you have this lecture. I just remember everybody tuned out and most people couldn't find the notes, so I just covered it. A lot of it you've actually already covered in HKS, or I don't even remember. But basically it's just a lot of terminology. So morbidity, mortality, you already know. Agent is the thing that actually causes the disease. Infectivity, pathogenicity, and virulence you have to know, but you should already know. So quick recap, infectivity is the capacity to cause infection. Pathogenicity is the capacity to cause disease. So basically how strong the actual pathogen is. And virulence, there are different definitions you get, but I think the one the lecturer gave was the severity of disease the agent causes in the host. Okay, you've seen this like 5 billion times, but the things you need for disease transmission, so you've got the chain of transmission, and we always want to break the circle or the chain of transmission, quite low yield. Although you might want to know that the easiest place to break it is right here at the mode of transmission place. So it's by like good hand hygiene, PPE, and all that jazz. Okay, so this is stuff we've already learned. This stuff I think might be slightly new and actually useful. So there's latent, incubation, and infectious periods. So basically, whenever you get like someone coughs on you and you get exposed to some kind of pathogen, you won't get symptoms straight away. There'll be some incubation period beforehand. So the incubation period refers to the period between the exposure to the agent, so when you get coughed on, and the onset of disease symptoms. So when you start to have, like, let's say, a sore throat. So you get the incubation period, so you're asymptomatic, and then you get the clinical disease, which is when you're symptomatic. So you've got the signs and symptoms of infection. And then you've also got this kind of like parallel time frame. Yeah, you've also got this like parallel thing where you've got a latent period and infectious period. So it's kind of completely separate, but the latent period is talking about when you're able to, when you're between the time you've been infected and when the infectious period actually starts. So once someone's coughing you and before you're actually capable of passing on that disease to other people. So the funny thing, not funny, the annoying thing about the latent period and the incubation period stuff is where is like this when you have coronavirus. So I'm sure we've already all heard that it's possible to have coronavirus without being symptomatic. And that happens when the incubation period is longer than the latent period. So it's actually quite a good example, and there's a nice little article from Bite Conversation here. But the issue with the coronavirus is that the incubation period, so the time between when you get infected and when you're able to pass on the disease, so the incubation period is actually, is it shorter? No, it is longer than the latent period. So when you're actually not infectious. So you can actually be infectious and asymptomatic at the same time. So this is bad because you can pass on the disease before you know you actually have the virus. So that's a problem. You should actually get to know these terms because I think there was one multiple choice question, or it might have been a quiz somewhere. Okay, and even more terminology. So these are more transmission terms. So index case is the first case in the population. So you might not always know who that very first person was, and so it might not be notified. And the primary case is the first identified and or notified. So the primary case is the one you actually know about, and the index case is the actual first one. Secondary cases are the ones resulting from subsequent transmission, and reproduction rate. So this is an important definition, is the number of cases one case generates on average over the course of an infectious period in an otherwise uninfected population. So if I get infected with coronavirus, I'm sorry, all the coronavirus references, it's a bit depressing, but if I get infected with coronavirus, let's say the reproduction rate of corona is 2, that means that I will pass on the virus to 2 other people. So using that logic, if your reproduction rate is greater than 1, so if I am capable, if I pass on the disease to more than 1 person, the number of cases are going to increase. Whereas if the reproduction rate is less than 1, the disease declines. So the larger the R0, the harder the disease is to control. And there are a few factors that influence R0. So the duration of the infectious period, the effectivity of the agent, the number of susceptible people, those things will all affect R0. You don't have to memorize that, but I think it's pretty logical. And then there's a nice little table here showing you like different R0s for different conditions or different pathogens. Yeah. So you can see measles is super, super infectious. 12 to 18 cases. Immunity, I think we already all know this. So it's a capacity of a person when exposed to an infectious agent to stay healthy, free from infection. And you can acquire that through prior infection or immunization. Herd immunity, I hope you already all know something to talk about that. Okay, even more terms. So endemicity, so you can have sporadic like outbreaks. So these are occasional cases occurring at irregular intervals. So little bumps at random intervals. Or can have endemic. So these definitions you actually do need to know. So endemics are like a persistent occurrence of a low to moderate level. So it's like kind of like bubbling away in the background, but it's not something to like super panic about. Hyperendemic is a persistently high level of occurrence. So it's not just bubbling, but it's kind of like boiling in the background. And epidemic is like an actual outbreak. So the difference, the difference between epidemic and a pandemic is a pandemic happens worldwide. I think we've already covered this. And only the WHO can cover it. So last year they gave the example of the swine flu in 2009, but this year on March 11, 2020, WHO declared COVID-19 a pandemic. Okay, and there are a few things you need for epidemic to occur. So you need a virulent agent, susceptible population. So you can't have immunity because otherwise you get stopped in the tracks. Opportunities for exposure, blah, 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 blah. You can read that later. You don't need to memorize that. Yes, and last slide is emerging infectious response strategies. So these things, so enhancing surveillance and response capabilities, encouraging applied research, strengthening public health infrastructure and training, these can all help kind of reduce outbreaks and epidemics and pandemics. Obviously that hasn't been implemented too well, but yes, that is the case. Any questions? Amazing. All right, someone else can go ahead. David, your hair is so long.
Yeah, it's so long now. Like, I think I'll just get a perm.
Okay, do you want me to go first?
My one's 10 slides. Do you want me just to quickly yeet through it?
Yeah, mine is, sorry guys, my sections for today are hella long, but I have notes for all of the sections. So I'll be going through like a 2-minute summary for each and you guys can just read the notes in your own time because my topics all suck this week.
For the psychopathologies one, like I remember that because I didn't go. And the lecture ran over time and they didn't get through like any of the conditions.
Yeah.
Right. I don't think I even went to
I didn't
that
go
lecture.
to a single psych lecture. So none of these notes are from like lectures. These are all from like either friends or like other PSPs.
All right, here we go. My thing is lagging, as you can see. Running Zoom and like Google Slides at the same time just destroys the RAM.
David, if you need more convincing to get a new laptop,
This is it.
just saying.
You know, I'm not buying for myself. I'm buying for like everyone in PSP. You know, so I'll just go buy. Okay. Here we go. 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 Almost there. How many slides do we have today?
They're all like mine. I apologize.
That's awesome.
Sorry.
No, that's awesome. All right, here we go. So, if this will load.
Your computer is so laggy.
Yeah, look. Ah, it's working. All right. So welcome back, everyone, to part 2 of Sem 2. And if anything, this is probably like the best part. This is where we start. This is where we start cardio. And if you know anything about me, is I love cardio. Cardio is one of the best parts of med. Even now in Sem 2, having like Sem 2 year 2, having done many of the other systems, I still find cardio to be one of the most interesting. So when we first did this lecture, I'm not sure about you guys, but when we first did this lecture, we had no idea even what a valve was. We had no idea what even a like a heart was, basically. So like it was really hard to kind of like conceptualize what the people were talking about. But like you don't need to worry about it. I'll make it really simple, hopefully, just through this infectious disease of the cardiovascular system. I do also have 1-page notes on this as well, which I will link on Facebook later. Good. So infectious disease of the cardiovascular system. Let's dive in. Some quick notes. Basically, they will like she comes and the lecturer comes like last year. She came and she's like back from Harvard, so she's like super big dog, and she's working at like Alfred now, and she goes through like so many diseases. But the main one you just need to be like knowing, and that's really high yield for later on in even year 2 pass exams, is infective endocarditis. So that will be like the main one I'm talking about. And we've got a gangster here with us. Oh, okay. Yeah, so essentially it's infective endocarditis, that's the main one. Everything else is kind of like not as important. They might go through it, but it's not as important. So who's hungry? So which one's lasagna and which one's endocarditis? I think that's actually kind of hard to tell with some of them, but like if you look closely, I'm sure you'll be able to discern which one they are. All right. So infective endocarditis is essentially an infection of the endocardial surface. Just think of the heart, right, being like a 3-layered thing. The outside is the pericardium, and then you've got the myocardium being the muscle, and then you've got the endocardium on the very inside. So endo, like inside, right? Like you've done, and your endothelial, like endothelial kind of cells is like on the inside as well. So endo being inside, endocarditis being the infection of the endocardial surface. Most commonly, it's on the heart valves that's impacted and can lead to septal defect. So that's like the wall that splits the heart into 2. Like, so if you think about it, like the infection from the heart valves kind of spreads outwards, and then that might like infect the wall of the heart inside, as well as the mural endocardium. So that's just like the wall of the heart. Like this is basically another word for it. Yeah, and it's usually caused by Staph aureus, our good old friend Staph, right? Oral strep, so Streptococcus species, as well as CONS, which stands for coagulase negative staph. So that's just called CONS. And you don't need to know too much specifically about the bacteria in itself. Infective endocarditis, clin skills is quite interesting to kind of see how it manifests. Thirdly, infective endocarditis is also quite aggressive, as the Staph aureus may be virulent and may cause like these structural cardiovascular diseases. So don't worry too much about the subacute either, but the main thing about the complications is it can lead to septic shock. So your bacteria kind of floating around in your blood, and that causing like this like over-inflammatory reaction and causing your blood pressure to drop a lot. Embolism, right? A blood clot kind of forming in like the ventricles or the atrium. So that's the top part of the heart, and like ventricles being the bottom part of the heart. An abscess like is just usually when there's like pus that kind of fills up. And if you think about that in the heart, that's really bad, because if you've got like pus and like these like bacteria infection in the heart, and then your heart pumps it all out, then it's like literally all over your body, right? But it is quite curable if treated. However, in hospital mortality is still quite high. It is still 20%, and 1-year mortality is quite high at 40%. So it is one of the more deadly diseases that we know. So in terms of pathogenesis, you guys can see the diagram here with like the heart. So you can see like the bacterial colonization in around the heart valves, like the flaps, right? And this is breach usually like injection, so that can be like through drug use, recreational drug use, or even through like IV cannulas, and as well as cardiac surgery. So it's cardiothoracic surgery, that is, where you insert like pacemakers and things like that. Or through the oral cavity when you have poor dental hygiene, or you have like post-dental procedures. I don't actually know exactly how the dental procedures causes it, but it's just like a buzzword for this. Furthermore, the route of transmission and pathogen is mainly through gaining access into the bloodstream. So that should be surge, not sung. And adherence to the kind of valve surface. So first you need to stick on it, and they need to not be killed off, and then you need to like kind of multiply, so proliferation. And then after it has proliferated, it just starts swimming around and just disseminating. Now, this is one of the most important kind of tutorial kind of bits that you need to know for infective endocarditis is essentially if an IV drug user, for example, they inject into one of the veins of your arm, so for example, your medial cubital vein, if you think about the kind of blood flow, how does that go, right? So your venous blood goes back to your right heart. So your right heart is where it would land first, okay? And the valve that it lands, like the blood that is carried back through the injected drug, will go back to the tricuspid valve, okay? So if you think about all the bacteria that kind of travels with it, the venous return, like the venous blood, all go back into the right side of the heart. And this is why the tricuspid valve is most likely to be actually infected with it for infective endocarditis, for IVD use, so like intravenous drug users. So just think of like how the blood actually moves back and the kind of infections that's associated with it. All right. Cool. I'm sorry, give me 1 second. Wait, what just happened? All right. So usually it's from mitral valve, and then aortic valve, and then your tricuspid valve, and then finally your pulmonary valve. You will learn the anatomy of the heart very well soon. I just won't go too much into it now. In terms of diagnosis and kind of investigations, what you need to do is, like, this is the most important thing, is to do 3 types of cultures. You do it 1 hour apart from each other, because sometimes it just doesn't come up initially. So you need to do it 3 times to make sure that it's essentially like legit, right? Like the culture is sort of reflective of the disease. Otherwise, it kind of, otherwise, like you're not sure if it is infective endocarditis or not. And it is important to do the esophageal echo. I can't pronounce words today. Transesophageal echo, as only that one, so the TOE, so toe, or like transesophageal echo, can reliably rule out infective endocarditis. Transthoracic echo isn't sensitive enough. So what does that kind of look like? So transthoracic is like you grab a ultrasound, right, and then you're just doing it here. But in terms of transesophageal, you literally like put a probe down your throat, and then they look into the heart like that. So it is far more invasive, but it is the only one that's reliable. And you would probably order bloods as you would with infection. So leukocytosis, that makes sense, right? You have increased amount of white blood cells as there are increased infection, and leading to also like C-reactive protein for kind of inflammation, as well as erythrocyte sedimentation rate, which is kind of the red blood cell and clotting kind of things. Yeah, so that's pretty much it. Just to note that Coxiella and Bartonella are 2 of the main things that have negative cultures, and you might need to do other investigations to look at that. But the main, like, highest yield thing for this in terms of diagnostics is to do 3 sets of blood cultures. So empirical therapies, if someone comes in really sick and you know they have an infection, like, you don't want to be like, oh, let's find out exactly what it is first. You just want to start giving them like broad spectrum antibiotics to like just make sure they're not dying, right? Like just make sure they're alive. So you just chuck them as much like the necessary kind of coverage for antibiotics as possible. So you give like native valve endocarditis. So that's like when your endocarditis is like, it's your own valve, so that's like IV drug use or something like that. So that's like penicillin and an aminoglycoside. And in terms of an inserted prosthetic valve, you would give vanc as it is a little bit more stronger, and a penicillin. Sorry, side note, can anyone, wait, Zoe, Peter, or Heidi, like, what class of drugs is vanc again? It is an aminoglycoside, right? That's why I'm like, wait, I read that twice then.
Vanco.
Like, I'm pretty sure vanc is an aminoglycoside, unless like
No, it's a glycopeptide.
Glycopeptide. Okay, yeah, never mind. They're different. So penicillin and aminoglycoside for like your own body, and then vanc is like really strong. So you want to use it for something that's not within your own body. So that's like your prosthetic valves. And in terms of causative kind of pathogens, you have like Staph aureus, strep, HACCP group. Like I had no idea what that meant, but it's just through revising it. HACCP group just basically means gram-negative bacteria commensal in your oral pharynx. And your HACCP group are usually subclinical infective endocarditis. So the symptoms are not as clear on that. As well as like fungal, right? Because you want to give empirical therapy as well. Sorry, you want to make, going back to here, we want to do 3 sets of blood cultures because we want to rule out that it isn't bacteria. So then we can be like, oh, it might be fungal. And then that can come from like surgery, drug use, or other prolonged antibiotics. And for kind of like the possible causes of a negative culture in terms of endocarditis is like fungal, right? Like fungal wouldn't come up on a bacterial culture. Like that doesn't make sense. And neither would like a parasite. And a subacute or end chronic infective endocarditis, which has just kind of like fizzled out, and then on a pacemaker wise, which unless they swab it properly, you won't be able to get it. So if you give the empirical administration, so I've already given the patient some antibiotics, then it will kill off a lot. And so when you do the culture, it might come off negative because you've already killed off most of it, and that's why the culture is negative. So some revision questions for infective endocarditis as well. We'll probably use some of the like 1 or 2 for Kahoot next week. So have a look there as well for your own revision. And if you seemed reading all the other slides, like just read this one. Like this is just like a 1 paragraph kind of summary of what infective endocarditis is. Okay.
I think like buzzwords for infective endocarditis is like yeah, it's like they get a tooth extraction or they're like an IV drug user.
Yeah. And like splinter hemorrhage, like I don't know if you guys will be tested much on like clin skills, but you see splinter hemorrhage and you're like, is this infective endocarditis?
Like splinter hemorrhages, Janeway lesions, and one more thing. Osler's nodes, I think. Actually, no. I think cancel that. Don't listen to me. I don't know what I'm saying. Splinter hemorrhages, tooth extraction, or IV drug user.
Yeah. IV drug use, just think about how the blood flows. Like, honestly, this is just cardio in general. Just think about where the blood comes from and where the blood flows. That's like anatomy and like just things in general now, like from now on. It's not about like stationary. It's all about relational in time and relation. Like next year, you guys will start doing like endo, and I'm like struggling with it because there's so many pathways, but just think about where it comes from and where it eventually goes, and it will be much easier for you.
Okay, so here's the deal, right? I'll go through brief summaries and I'll take you guys through the notes. And basically, if you have any questions at any point, I'll try and answer them. I don't actually remember a lot of the psychopathology because I remember that was like the one thing last year that took me a long time before exams to actually like memorize, if you will. So anyway, oh wait, let me actually like hold on a second while I actually get my notes up.
How do you do the filters?
You go to like preferences, and then there's like background and filters now. You have to update though. It's like with the
Yeah,
new
have to
Zoom.
update the Zoom.
Oh wait, my laptop's not good enough.
Oh wait, I
Sounds
was
like
wrong.
yours.
What am I in? Oh my god. Okay.
Wait.
Sorry guys. This is taking me a hot minute.
It's under like video and
Wait, why is it mirrored? Is it mirrored for you? Was it the
No,
it's the right way
it's
around.
mirrored for you, but it's not for us. Yeah.
Typical gangster.
Did I not put it? Oh, okay. Aish. Sorry guys, my brain is a little bit fried right now. I was just reading a Lancet paper on the complications of COVID.
Is this assignment?
Okay, here we go. Here we go. So this is a big, long document. Oh my God, David. This is a big, long document on all of the psychopathologies, the models, everything that kind of goes, not like, I won't say goes wrong, but like, you know, we're talking about like psychopathologies, right? So we're talking about like psychological disorders, how they happen, how we suspect they happen, how they change with time, and how they're like related to specific developmental stages. Correct me if I'm wrong, but like they talk about a lot, right? And there are only a few that were kind of like high yield in the end. I tried to memorize, I went on like a binge and I was like trying to memorize everything and it just wasn't happening. You don't need to know, like if you look here, right? You don't need to know like absolutely everything, especially with like these personality and anxiety disorders. Like look at this. There's lots of different things. There's lots of different kind of disorders that we'll go through. They don't even go through all of them in the lecture, so like just FYI. So most importantly, as we've been talking about with psych in general, any like sort of developmental psychopathology is going to result from many different causes. You're going to have different factors that are going to interact in a dynamic way, and that's what's actually going to cause the psychopathology, right? That's what we can conclude now, is that it's not one specific cause, it's a multiple, like a range of different things that will interact. So we've got 4 models of psychopathology. So you've got your psychodynamic, which is Freud. You've got your behavioral approach, social cognitive approach, and biological approach. Honestly, just like know a little bit in general about all 4. I'm like honestly can't really recall, but I don't think there were actually that many questions regarding this on the end of year exam, but that could have just been because the last year's exam was a bit of a blur to me, but yeah. So defining mental disorders, we want to do this because defining them will improve clinical outcomes, right? Like if you have a patient presenting, you want to know what's affecting them so you can actually help them improve in the future, clinical outcomes. So your definition will be based on the cluster of symptoms as well as the impact on their functioning, as well as following like a diagnostic manual, referring them further to a specialist. So it's basically symptoms will range from normal to impaired. So you're not just going to like, you know, because of like today's lecture, you'll go like, oh, okay, so like someone presents with these symptoms, I'm just going to like casually just diagnose them with ADHD. No, like there's a whole like range of things that has to happen before someone will actually get diagnosed. But yeah, taking that first step, which is why like primary healthcare is really important, because normally the first point of contact is going to be family GP. So people are going to come, they're going to notice something's going wrong. And so actually taking those extra steps is really important, which is why primary healthcare is such a big thing that we'll be talking about a lot. And you'll be talking about it next year as well. Okay, so this is split into 2 sets. So we've got psychopathology in children and adolescents, and then we've also got psychopathology in adults. So these, however many, I think there's 4, are actually all quite significant. They're big brain, like there's a lot of knowledge, there's like a lot of information here. But basically you guys can kind of go through it yourself. Does anyone want to like chime in with anything that they remember was really ridiculously important?
I do not remember any of this.
See, that's what I mean, right, guys? I didn't know if it was just me, like not remembering stuff that like the questions on the exam, but it genuinely isn't actually on the exam much.
Wait, for ADHD?
No, just like psychopathologies and like.
Oh wait,
I
the
think I just
personality
guessed.
disorders had one multiple choice question.
Which one?
Personality.
Okay. I remember personality disorders, but I don't remember like there being anything on this sort of stuff. So just know, like definitely, like you don't need to like memorize all like every single little detail about them. You need to know like general overviews of all of these conditions, I would say, but don't like beat yourself up about it if you don't remember like all of the different like pharmacological treatments and all of like the DSM-5 diagnostic criteria. Like you're not gonna be diagnosing people from like this, right? Like
I think I just guessed, honestly.
And for personality disorders, if you're very keen, like what I did, I wouldn't call myself keen, but like you have cluster A, B, and C, and then just know what belongs under each. So cluster A is your paranoid, schizoid, and schizotypal. Cluster B is antisocial, blah, 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 and cluster C is that. Like I think that the multiple choice question that was an exam, I don't know if I remember this correctly, was they had like a very small prompt about a girl who was very nervous but neurotic, and then we had to determine which borderline personality disorder she had, and I believe she had the avoidant personality disorder. Don't remember exactly, but there was one multiple choice question. So
I really don't remember. I think I just said like borderline personality disorder. Like I think that was one of the options, and I was just like, yeah, just pick that one. That's the only one I recognize, and I moved on. So yeah. Basically what we've all said, like you just need to know general overviews. And then psychopathology in adulthood and later life is divided into 2. So you've got personality disorders, which are a series of maladaptive personality traits that deviates from expectations. And then you've got, I'll scroll back, guys, don't worry. And then you've got the second one, which is anxiety disorders. So once again, like Zoe said, the personality disorders are divided into 3 clusters. Honestly, just know like some brief overviews. You don't need to know like all of these in a lot of detail. And honestly, if you get asked about like, oh, what is like histrionic personality disorder? Like it'll be like a really niche sort of question. I took so much time trying to make these notes pretty. Borderline personality disorder is one of the ones that they talk about a lot. Like I remember, like I don't know why I remember this one the most, but somehow it just stuck with me, borderline personality disorder. And then you've got anxiety disorders, which is kind of just, they've just lumped that in general. And that's, you can go through that yourself. And then they talk about the 3-step theory of suicide. And suicide prevention. But once again, not really examinable on the exam altogether as a whole. But here are all the notes. Feel free to go through them in your own time. Please don't stress about all the really like nitty-gritty little details because it's not worth your time memorizing all like the really like specifics. Okay. And now I'm going to move on to diagnosis and screening, right? Once again, there are also notes for this. I have put a summary of the really top high yield stuff in the slides. But yeah, go through them in the notes. Feel free, because I've kind of rushed through today. If you have any questions, feel free to just message me if you want more detail or if you want to clarify anything. But yeah, diagnosis and screening. This one was taken by Robin Bell. I think it was actually a pretty good lecture overall. But yeah, so main thing that they go through is the difference between obviously like diagnostic and screening tests. So a diagnostic test is a test that is used in someone presenting with symptoms, where the test is actually used to establish the correct diagnosis. So we're using a mammogram to investigate a woman who presents with a lump in her breast. So she's already presented with a symptom. Now we're going to refer her to get a mammogram to actually investigate further whether we can get a diagnosis after that. Screening test, however, is a test used to detect a disease in an apparently healthy population. So that would be the women aged 50 to 60 are invited for screening mammography every 2 years. So that's screening. And then diagnostic is actually like you're diagnosing. Well, you're trying to reach a diagnosis. So kind of in the name, kind of easy to remember. This is the very high yield stuff, guys. This is the maths, all like the positive predictive, like you get like this table and you have to do some cool fraction stuff. And yeah, this is actually very high yield. This is 100% going to be on your exam. And there'll be like 4 or 5 questions. It'll be like is it an EMQ? Is that, no, I think it's an EMQ.
Yeah, like an EMQ. And it's always like, what is the sensitivity? What is the specificity? What is the PPV? What is the NPV?
Yeah.
4 marks every single time.
Every single time. There is a really good Moodle quiz that I basically did with a couple of my friends. We did it once and got like 30% because none of us went to the lectures, and then we revised and then we did it again. And basically those exact same questions were repeated on the exam. So do the quiz. The quiz is really good. So we've got, basically you will get given this table around, like if you can see this one. So it'll have test positive, test negative, disease present, disease absent. So you'll have values for true positive, false negative, true negative. I think that's supposed to be negative. Just excuse me for that. I'll fix that in the notes. Whoops. So then you'll be asked to calculate sensitivity, specificity, PPV, and NPV. And the definitions are all there. This is sort of a memory thing, unfortunately. But yeah. Definitely high yield though on the exam. It will be, like, we can 100% guarantee. And lastly, lead time, length time. More importantly, I think for this is actually the bias. So what is lead time bias? What is length time bias? So I think the one that confused me the most was lead time bias, because the way that they described it in the lecture was like, what the hell? So I've written it extra in both the notes and down here in the presentation notes. So lead time is the length of time between the detection of a disease and its usual clinical presentation and diagnosis. So it's when you do a screening test and you get like an early diagnosis, it's like that time between early diagnosis with that screening test and the time in which the diagnosis would have been naturally made without the actual screening. So the bias that presents with lead time bias is that early diagnosis of the disease makes it seem like people are actually surviving longer when it's not actually the case. The course of the disease is unaffected. And then we've got length time bias, is where cases are diagnosed through screening tests that would have never presented clinically and never kind of like been picked up if it had not been for the screening test itself. So yeah, so they tend to pick up diseases that are like a little bit rarer, less aggressive, and that won't actually present clinically for potentially many years. So yeah, most important for lead time, length time is actually just knowing the biases, because I'm pretty sure they will ask about some of this stuff. And lastly, PNS lower limb exam. I think main takeaway is just refer to your clinicals notebook. They're quite good with actually putting everything that you need to do in a table, putting everything that all of like the key information. If you really want extra detail, please refer to Tally. Tally is a fantastic resource, except I think they don't actually have the neurological exam. Well, apparently like the neurological exam in Tally isn't actually very good, but that's rumor. Like I use Tally all the time. But yeah, your Clean Skills notebook is very good. It is based on Tally. So once again, great resource. My notes are up on the drive. They're not very different to the Clean Skills notebook, but I set them out in like maybe a way that helps. My biggest takeaway and piece of advice is you always have to compare sides as you go, because if you don't, you will fail. That's just blanket rule. And when you are testing the knee reflex, please don't stand in front of the patient because you are going to get kicked. And that's like, you won't, like, obviously you won't be doing it now, but like when you eventually go and like practice in real life, please don't stand in front of the patient when you're doing a knee reflex, because it can hurt if you get kicked. And
Also,
that is it from me. Oh, no,
yeah.
Zoe.
Oh no, just this is unpopular opinion, but if you can, learn your dermatomes and myotomes. Not many people did, like especially myotomes, it's not required, but I personally found it useful and kind of fun to link it to anatomy as well. So if you have your hip adduction, nerve roots at L234, if you think about it, wow, that corresponds with the nerve roots of the obturator nerve L234. Wow, amazing. And like even like leg extension, gluteus maximus, superior gluteal nerve L4, L5, S1, S2. Wow, it like blows your mind. So like try to link everything together. It's actually really fun. Yeah, I don't know. I don't feel like
it actually, like, definitely what Zoe said, it's actually really useful. My friends and I learnt the myotome dance, which is like, I can't remember it now, but there was like C1, like C5, C6 pick up sticks, which is like this or something, and like put them down, or like there's like dances and there's like different mnemonics. Like some are quite rude, so I won't say them because we're recording, but there are some that are like good, like they help you remember. Like anything that helps you remember the dermatomes, myotomes, like will help. Dermatomes are easier to memorize because they kind of like, you kind of just remember them in patches. You kind of go, okay, if it starts here, then it just goes down like 1, 2, 3, 4, blah, blah, blah. Like they're quite easy because you just need a starting point. Whereas myotomes, if you do the dance, like there is one on YouTube that is very good that we can link if you guys are interested. And just like while you guys are at quarantine, like get some of that, like, you know, extra workout movements, I guess. And yeah. Oh, sorry, I didn't look at the chat.
No, there's nothing.
Oh yeah, so I forgot to put the developmental psychopathology one up in the drive, but I'll do that now.
I think that's everything, right?
Zoe, or did she already present?
Zoe already presented.
Yeah, Zoe
that's
presented.
everything. Okay, I thought.
Yeah.